Hello and welcome to Chronic Pain Tips for Patients. I'm Dr. Yuri Martins. I'm a board certified pain management physician, and in this podcast, I will discuss chronic pain, pain treatments, and practical information to help patients better understand their conditions and their options. Today, we are going to talk about a topic that comes up very often in the pain clinic: marijuana, CBD, THC, and other cannabis-related products for chronic pain. Some patients ask me about this quietly, almost if they are embarrassed. They may say, "Doctor, what do you think about medical marijuana?" Other patients are already using cannabis products. They may be using CBD gummies, THC products from a dispensary, topical creams, or a combination of products. Some say it helps their pain. Some are not sure if it's helping, but they are afraid to stop because they have already tried so many other treatments. And I understand that. Chronic pain can be frustrating, exhausting, and life changing. When pain continues to months or years, it's natural for patients to look for relief wherever they can find it. Cannabis products are widely advertised. In many places, they're easy to access. They're often described online as natural, safer, or even as an alternative to prescription medications. But the real medical question is not whether cannabis is popular. The real question is, does it actually help chronic pain? And is it worth the risks? The honest answer is sometimes, modestly, as an adjunct, and not for everyone. The first thing patients should understand is that cannabis is not one single treatment. There are many different cannabis derived products, and they are not medically equivalent. Some products contain mostly THC. THC is the psychoactive component of cannabis. It is the part more likely to cause a high, dizziness, impaired attention, slowed reaction time, and change in perception. Some products contain mostly CBD. CBD usually does not cause intoxication, but that does not mean it's risk-free. CBD can still interact with medications, may cause adverse effects, and may not be effective for many chronic pain conditions. Some products contain a combination of THC and CBD. Others are marketed as full spectrum, broad spectrum, hemp derived, medical cannabis, recreational cannabis, prescription cannabinoids, dispensary products, oils, gummies, creams, and tinctures. This matters because the scientific evidence is not the same for all of them. When patients ask, "Does cannabis help pain?" I usually explain that we need to ask a more precise question: which cannabis product, for which pain condition, at what dose, and for how long, and compared with what other treatment. Without those questions, the conversation becomes too vague to be medically useful. Cannabis use for chronic pain has increased substantially in the United States. Medical cannabis program enrollment has grown over the last several years, and chronic pain is one of the most common reasons people seek medical cannabis certification. In one large survey of adults with chronic pain living in the states with medical cannabis programs, about 31% reported that they had used cannabis at some point to manage their pain. About 26% of these chronic pain patients had used it in the past year, and about 23% had used it in the past month. So many patients are not just curious about cannabis, they are already using it. That is one reason I believe physicians should discuss this topic openly and without judgment. If patients feel embarrassed to mention cannabis use, they may not tell their doctor. That can be dangerous, especially if they are also taking medications such as opioids, benzodiazepines, sleeping pills, muscle relaxants, antidepressants, blood thinners, and other medications that may interact with cannabis or increase sedation. A good pain clinic visit should be a place where patients can ask these questions honestly. So, what does the evidence actually show? The best available research suggests that cannabis derived treatments may reduce chronic pain in some patients, but the average benefit is usually very small. That does not mean the benefit is meaningless. In chronic pain medicine, even a modest improvement can matter if it helps a patient sleep better, walk further, participate in physical therapy, reduce reliance on other medications, or function better during the day. But it does mean that patients should be cautious about dramatic claims. Cannabis is not a cure for chronic pain. It does not reliably eliminate pain. It does not work for every pain condition, and for many patients, the risk may outweigh the benefits. The strongest evidence appears to be for certain THC-containing or THC and CBD balanced products in some forms of neuropathic pain. Neuropathic pain is pain caused by nerve injury or nerve dysfunction. Patients may describe it as burning, shooting, electric, stabbing, tingling, numb, or hypersensitive pain. Examples include diabetic neuropathy, nerve pain after surgery or trauma, multiple sclerosis related nerve pain, spinal cord injury related nerve pain, and some other persistent nerve pain syndromes. Even in these conditions, the benefit tends to be modest, at best. In large reviews of randomized clinical trials, cannabis-based medicines were associated with small improvements in pain, sleep, and physical function. One way to explain the size of the benefit is this. Compared with placebo, approximately 10 additional patients out of 100 may achieve a minimally important improvement in pain with non-inhaled medical cannabis or cannabinoids. That's not zero, but it is also not the miracle effect that is sometimes advertised. CBD alone is less convincing for chronic pain. Many patients are especially interested in CBD because it's widely available and usually does not cause intoxication. CBD is marked for almost everything: pain, sleep, inflammation, anxiety, arthritis, and general wellness. Unfortunately, marketing has moved much faster than the science. For chronic pain, the evidence for CBD-only products is very weak. Some small studies suggest possible benefits in selected situations, such as topical CBD for peripheral neuropathy. However, better controlled trials of oral CBD in arthritis and osteoarthritis have generally not shown meaningful pain relief. This is important because many patients spend a lot of money on CBD oils, gummies, capsules, and creams, assuming they are using an evidence-based pain treatment. In reality, CBD-only products may help some individuals, but the overall research does not support CBD as a reliable treatment for chronic pain in general. Another concern is product quality. Over-the-counter CBD products are not always consistent. The amount of CBD listed on the label may not match the actual amount in the product. Some products may also have THC, even when patients do not expect it. Others may contain contaminants or ingredients that are not clearly disclosed. For a patient who is subject to drug testing, takes multiple medications, has liver disease, or is older and at risk for falls, these details matter. THC may be more likely to reduce pain, but it carries more risk. Many of the more positive chronic pain studies involve products that contain THC. That makes sense biologically because THC interacts with cannabinoid receptors in the nervous system and may influence pain processing. But THC is also the component more likely to cause impairment. Common THC-related risks include dizziness, drowsiness, impaired attention, slow reaction time, dry mouth, nausea, anxiety, feeling intoxicated, and short-term cognitive changes. These risks are not trivial. For some patients, dizziness or sedation can increase the risk of falls. For others, impaired attention can affect driving, work, childcare, or decision making. THC may worsen anxiety or panic in some people. In patients with a personal or family history of psychosis, bipolar disorder, or certain severe psychiatric conditions, THC may be particularly concerning. THC can also become habit-forming. Not every patient who uses cannabis develops cannabis use disorder, but the risk is real, especially with frequent use, younger age of initiation, or used to cope with sleep, mood, or stress. This is why people often hear the phrase start slow and go slow. But even that phrase should not be used casually. Some patients should not use THC at all. Others should only consider it after a careful discussion of risks, goals, medications, medical history, and alternatives. If you're thinking about starting any form of cannabis for the treatment of a medical condition, I strongly recommend that you talk to a doctor or another qualified healthcare professional first. Cannabis related products can cause complications, especially if you have pre existing medical conditions or take other medications. Based on current evidence, cannabis derived products may be more reasonable to discuss in selected patients with refractory neuropathic pain. Refractory means the pain has not responded to standard treatments. Examples may include selected patients with diabetic peripheral neuropathy, nerve injury after surgery or trauma, multiple sclerosis related central pain, spinal cord injury related nerve pain, or other persistent nerve pain syndromes. Even in these situations, I would not describe cannabis as a first line treatment. Standard treatments may include physical therapy, specific non opioid medications, behavioral strategies, interventional procedures when appropriate, sleep optimization, and treatment of contributing conditions. Cannabis may be considered as a part of a broader plan, but not as a substitute for a complete pain evaluation. The evidence is less convincing for many common chronic pain conditions, including chronic low back pain, osteoarthritis, generalized body pain, and many mixed pain syndromes. Some patients with these conditions may report improvement, but the clinical trial evidence is not as strong or consistent. Fibromyalgia is another area where the evidence remains uncertain. Some small studies suggest possible benefit from THC-containing products or NAB alone, but the studies are limited and not enough to make broad claims. Cancer pain is also very complex. Earlier studies of THC and CBD products suggested possible benefit, but later larger trials did not consistently confirm strong results. One of my concerns as a pain physician is that cannabis can sometimes become a shortcut. A patient has pain, the patient tries cannabis. If it helps sleep or reduces distress, the patient may continue to use it without ever receiving a full diagnosis or treatment plan. But chronic pain is not one disease. Back pain may come from discs, joints, nerves, muscles, sacroiliac joints, spinal stenosis, inflammatory disease, or other causes. Leg pain may come from neuropathy, radiculopathy, vascular disease, or musculoskeletal problems. Shoulder pain, neck pain, pelvic pain, headaches, and widespread pain all require different evaluations. If we do not understand the source of pain, we may miss treatments that are more appropriate and more effective. Cannabis may change the volume of the pain signal for some patients, but it usually does not correct the underlying pain generator. It does not decompress a pinched nerve. It does not stabilize an arthritic joint. It does not reverse severe spinal stenosis. It does not replace rehabilitation. It does not treat depression, insomnia, or trauma in a comprehensive way, even if it temporarily changes how those symptoms feel. The goal should not be simply to numb pain. The goal should be to understand the pain, reduce suffering, improve function, and help the patient regain as much life as possible. Another important point is that cannabis related products are not regulated in the same way as prescription medications. When a physician prescribes a standard medication, the patient and the doctor usually know the active ingredient, the dose, the concentration, the manufacturer, and the expected range of effects and risks. If the patient refuses the same medication, the expectation is that the product will be essentially the same from one refill to the next. Cannabis products are different. Depending on the state, the dispensary, the manufacturer, and the type of product, there may be much more variability in what the patient is actually receiving. Two products may both be labeled as CBD, THC, full spectrum, or indica, but that does not mean they have the same chemical composition, concentration, purity, or clinical effect. This can create a very real problem for patients. I have seen patients with neuropathic pain who tried cannabis products and felt meaningful relief. Their burning, shooting, electric pain became more tolerable. They slept better. They felt that finally something was helping. Then the product changed and the benefit disappeared. Sometimes the dispensary stopped carrying that specific product. Sometimes the manufacturer changed the formulation. Sometimes the patient bought what seemed to be the same product, but the concentration or composition was different. Sometimes the patient could not identify exactly what they had used the first time. Then the patient may spend months trying to recreate the effect. They may buy different products, change brands, change ratios, and experiment with new formulations. But because they never knew exactly what worked, the specific THC concentration, CBD concentration, minor cannabinoids, terpenes, dose, route, manufacturer, or batch, they may never find the same relief again. This is one reason I caution patients to be very careful with poorly characterized cannabis products. When possible, patients should prioritize products that are more standardized, more regulated, and more transparent about their contents. At a minimum, patients should know the amount of THC and CBD per dose, the THC to CBD ratio, the manufacturer, the batch information, and whether the product has been tested by an independent laboratory. For chronic pain treatment, consistency matters. If a product helps, you want to know exactly what it is. If a product causes dizziness, sedation, anxiety, or cognitive impairment, you also want to know exactly what it is. Without that information, cannabis use becomes less likely a controlled medical trial and more like repeated experimentation. That does not mean every cannabis product is unsafe or ineffective, but it does mean patients should be cautious. A product that is poorly labeled, inconsistently produced, or vaguely described is harder to evaluate medically. In chronic pain care, we want treatments that are not only potentially helpful, but also reproducible, trackable, and as safe as possible. Another important point is that any treatment for chronic pain should have a goal. If a treatment is not improving pain, function, sleep, or quality of life in a meaningful way, it's reasonable to reconsider whether it should continue. This applies to cannabis. It also applies to medications, supplements, procedures, and other therapies. Patients should ask, what exactly is this treatment helping me do? Am I sleeping better, walking farther, functioning better, using fewer rescue medications, participating more in physical therapy, having fewer severe pain flares? If the answer is no, then continue the treatment indefinitely may not make sense. My practical view as a pain physician is this. Cannabis should not be promoted as a harmless cure. Cannabis-derived products may have a role in selected patients with chronic pain, especially some forms of nerve pain, but they should usually be considered as an adjunct to a broader treatment plan. The expected benefit is usually small. THC-containing products appear more likely to have analgesic effects than CBD-only products, but they also carry more risks. CBD-only products are popular, but the evidence for chronic pain is much weaker than many patients realize. For patients, the key is not to make this decision based on advertising, social media, or anecdote alone. The key is to make the decision medically. That means understanding your diagnosis, reviewing your medications, discussing your risks, defining your goals, making sure cannabis is not distracting from treatments that may be more appropriate from your specific condition. Chronic pain care should be individualized. Some patients need physical therapy. Some need injections or procedures. Some need medication adjustments. Some need better sleep treatment. Some need help reducing inflammation, improving movement, or calming an overactive nervous system. Many patients need a combination of these approaches. Cannabis may have a role in selected patients, but it should be only one possible tool in a much larger toolbox. If you're living with chronic pain and wondering whether cannabis, CBD, injections, medications, physical therapy, or other treatments may be appropriate for you, consider speaking with a pain specialist. We can evaluate the full picture. The best treatment plan starts with the right diagnosis. To learn more about chronic pain conditions and treatment options, visit my website at www.ycmartins.com or contact my clinic to schedule an evaluation. Thank you for listening to Chronic Pain Tips for Patients. Please like, comment, or do any possible interactions with this podcast. I'm Dr. Yuri Martins, and I will see you in the next episode. This podcast is for educational purposes only and does not replace medical advice. No content in this episode should be used as a substitute for direct medical advice from your doctor or another qualified healthcare provider. Cannabis laws vary by state, and cannabis or CBD products are not appropriate for every patient. Always discuss your specific situation with a qualified healthcare professional. Any views, thoughts, and opinions expressed in this podcast are solely those of the speaker and do not necessarily reflect the views, opinions, policies, or positions of the speaker's employer, company, institutions, or other associated parties.